Welcome. Thank you for joining us. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so that we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all to our guest speaker. Joining us today, we have Dr. Kristin Burke. Dr. Burke is an inflammatory bowel disease doctor at Mass General. She's the medical director of clinical operations for the Crohn's and Colitis Center, as well as an instructive medicine at Harvard Medical School. She specializes in the care of patients with Crohn's disease, ulcerative colitis, and microscopic colitis. Her research is focused on predicting response to therapies for inflammatory bowel diseases and the pathogenesis of microscopic colitis. In recognition of World Inflammatory Bowel Disease today, which is today, she joins us to give a talk on inflammatory bowel disease, particularly Crohn's disease and ulcerative colitis. So please join me in welcoming Dr. Burke.
Hello, everybody. Thank you so much for the introduction and thank you for having me today. Happy World IBD Day, everybody. So as Amy said, I'll be speaking to you about the management of inflammatory bowel disease in 2023. This is a rapidly evolving field with a new, very exciting therapy that was actually just FDA approved yesterday that we'll talk about too. These are my disclosures. I have received some consulting fees, none of which are relevant to this talk. So today, this is an outline of what we're going to be doing. I'll be speaking to you a little bit about the pathogenesis of inflammatory bowel disease and kind of the natural progression of disease if it's untreated. A treat to target approach that we use for management of inflammatory bowel disease in 2023. So right patient, right drug, right outcome. We're going to do that in slightly out of order so we can spend some time focusing on the drugs, the management that we use today. We'll talk a little bit about drug optimization and combination therapy. And then one question that we get from everybody is about de-escalation of therapy. So let's get into the pathogenesis of inflammatory bowel disease. First, just classifying. So there are two main classes of inflammatory bowel disease, Crohn's disease and ulcerative colitis. There are other forms, microscopic colitis, and then inflammatory bowel disease unspecified. Thinking about these two main phenotypes, there's two major differences. So Crohn's disease can affect anywhere from the mouth to anus. However, wherever you get the disease at the time of diagnosis is most often where it stays. The other defining feature of Crohn's disease is it affects the whole thickness of the wall. So why is that important? Well, if the whole thickness of the wall is inflamed, that area that's chronically inflamed can scar down and cause tightenings called strictures, which cause blockages. That inflammatory process can also burrow from loop of bowel to loop of bowel or out to the skin or other organs, causing penetrating or fistulizing disease as well. Conversely, ulcerative colitis is only confined to the colon. It does not involve any other organs. And it does typically ascend from anus up to the cecum. And so if it's just the rectum that's involved, that's called proctitis. If the left side of the colon is involved, that's called distal colitis. And then if the whole colon is involved, that's called pancolitis. Unlike Crohn's disease, it only affects the inner lining of the colon wall. So it shouldn't be able to burrow to other organs or to stricture. That being said, it can still be severe. The ulcers can be really deep and cause significant bleeding and other complications. Not only is the GI tract involved in inflammatory bowel disease, but there are extraintestinal manifestations. The three most common organs involved are the eyes with inflammatory processes like episcleritis and uveitis, the skin. The two most common things are erythema nodosum, which are these bumps on the shins that often go with flares, or pyoderma gangrenosum, which is like an ulcerating disease that is often independent of disease flares. And then the joints. So people can get spondylitis, sacroiliitis, and an IBD-associated peripheral arthritis. And there's actually two types, one involving large joints that typically goes with flares, and then one involving small joints that typically does not go with flares. So how does IBD happen? We have spent a long time studying this internationally and specifically at Mass General. Our current kind of working hypothesis is that there is a dysregulated immune response to changes in the luminal or the GI microenvironment, which includes the microbiome, triggered by an environmental trigger in a patient with a genetic predisposition. So this graphic kind of shows the evolution of development of inflammatory bowel disease. And in the panel over to the left here, you can see there's somebody, GI wall looks normal here. This is somebody with an underlying genetic predisposition. They get or are exposed to an environmental trigger, and then the disease initiates. There's loss of the integrity of the barrier of the epithelium. There's microbiome changes and dysbiosis. And in response to that, there's an expansion of the autoinflammatory process, an activation of different immune processes, ultimately leading to enough tissue destruction to lead to an IBD diagnosis. This is the progression of damage and inflammatory activity in a Crohn's disease patient if left untreated. I would say this actually does not apply to everybody. People with Crohn's disease, they're actually progressors, which this would represent, and non-progressors. And we work really hard to figure out who's going to be who at this. But as you can see to the left here, there's disease onset. Then people start having symptoms, and ultimately, if untreated, there can be complications like the stricturing from scar tissue, development of fistulas or abscesses, risk of surgery, and then further stricturing or complications of such. We like to catch people as early in the diagnosis and treat them as early as possible to prevent everything to the right here. And we really do have a great window of opportunity in 2023 to do this. So how do we do it? We use a treat to target approach for management of IBD. So again, our kind of mnemonic is right patient, right drug, and right outcome. We're going to go a little out of order so we can focus on the drugs at the end. In terms of right patient, well, there's no wrong IBD patient, but what we mean is we want to catch people early in the disease course and with objective evidence of inflammation. We want to target specific outcomes, and the gold standard is endoscopic remission of disease. The holy grail is histologic remission. And then patient-reported outcomes, how you all feel, really matters. And how do we do this? Using the right drug. We want to choose a medication that's personalized to your dominant pathways based on your biomarkers, based on your disease phenotype, something that's effective for any extraintestinal manifestations that you might have. And we always want to balance the efficacy, safety, and mode of administration. So again, right patient, really better named patient factors. There's no such thing as the wrong IBD patient. So the first thing we look at is just risk stratification. So how old were you when you were diagnosed? If this is a Crohn's patient, how extensive is your disease activity? Do you have penetrating complications or stricturing complications? Have you had surgeries before? Any deep ulcers? These are features that would make us choose potentially a more aggressive treatment strategy. And then if you have ulcerative colitis, similarly, how old were you when you were diagnosed? How severe is your endoscopic disease? Have you been hospitalized for your colitis? And are you losing enough protein from your colon from the disease that some of your blood markers are low? So once we've risk stratified you, again, we want to treat you as early as possible. This is a recent meta-analysis from Ben Horan's group in Israel, where they looked at all of the placebo-controlled clinical trials for Crohn's disease. And on the x-axis, you can see here time from the disease onset. So 0 years, right? This is right at when your disease started, all the way to 20 years after disease diagnosis. And then on the y-axis here, we have the proportion of remission at induction. And what we can see is the earlier you're treated in your disease course, the more effective the medications that we use are. And you can see that in both the treatment and placebo groups, the efficacy goes down the longer that you have disease. This is a really old study or older study from 2012, but highlights important concepts. So this was back when we only had anti-TNF therapies to treat Crohn's. And what we know is not only did people need to be treated earlier for disease, but in doing so with early use of biologic or small molecule therapies, we actually decrease the risk of two really important outcomes. So the graph on the left looks at the need for continuous corticosteroids in patients that were started immediately on an anti-TNF versus those who, again, this is kind of old school, got an immunosuppressant or an immunomodulator, like a thiopurine, like azathioprine or 6-MP. And then we're stepped up to anti-TNF, or really old school kind of traditional step-up therapy where you get kind of mesalamine first. And we see that at all of the time points here, people who got early biologic therapy had a lower risk of needing steroids, continuous corticosteroids. And similarly, on the right, these solid black lines here, these are people that got anti-TNFs really early. And we can see that they had a lower risk of surgery at all time points as compared to patients who had step-up therapy using the old school. So we know that treating early can improve outcomes, decrease the risk of long-term steroid use, decrease the risk of surgery in Crohn's disease. So that's right. Those are the patient factors we consider. Now, what outcomes are we looking for? So whenever I meet a new patient in clinic, I always tell them there are 3 depths of remission that we really care about. The first one's called clinical remission, resolution of your symptoms. And of course, this is what patients want, right? They want to feel good. And this is clearly very important, but actually for us, it's just the icing on the cake. The next level of remission is called endoscopic remission. And this is truly the holy grail, and we'll talk about why. One level deeper than that is histologic remission. So we look in with our scope, and not only do we see a normal, I'll say colon, but also small bowel organ, and we take biopsies of it. And under those biopsies, we see totally normal tissue or no evidence of inflammation. Histological healing is not yet achievable for every patient, but that's okay. We know that endoscopic healing predicts the most important outcomes. So why do we go for endoscopic healing? Well, specifically in Crohn's disease, not so much in ulcerative colitis, we know that clinical symptoms actually don't always match the mucosal appearance. So again, this is a scatter plot looking at Crohn's disease endoscopic activity, so what we see when we do a colonoscopy versus what a patient feels. And you can see that there's no way to draw a line on this scatter plot. There's really no tight correlation. Some people feel really bad, but their colonoscopy looks really good. And conversely, people can have a colonoscopy that looks really bad, but feel great. And so we always do need to look to make sure that we've achieved endoscopic healing, because that predicts outcomes. So what outcomes does endoscopic or mucosal healing predict? Well, 3 super important things. One is durable remission. So we know that if we can get you to appear endoscopically normal on exam or in remission endoscopically on exam, that we're going to decrease your risk of future flares. We know that we're going to improve your quality of life and productivity, which are important outcomes to patients that I speak with, and then decrease your risk of surgery. So how do we do this? We do this using the right medication. Before I get into the right medication, I do want to speak about 2 medications that have been around a long time and kind of the role of these medications in the management of IBD in 2023. So the first is aminosalicylates. So back in the day, this used to be kind of all we had other than steroids for management of disease. But in 2023, the role of aminosalicylates, so this is mesalamine and a lot of formulations, of mesalamine. They're only indicated for induction and maintenance of remission for really mild to maybe moderate ulcerative colitis. It's great when we can use them because they're tolerated well. There's not a lot of side effects. We're not immunosuppressing you. But we know they only touch the real inner lining of the colon. And so they're no longer recommended or indicated for Crohn's disease. And for people that have severe UC, they're not enough to gain control. So they have a very limited scope in 2023. Similarly, steroids. I mean, steroids are a double-edged sword. They can be really great for people that are in the midst of a severe flare. They improve symptoms really quickly, can help get you into remission very quickly. And if you're hospitalized for inflammatory bowel disease, IV steroids can turn things around for you in a great way. That being said, we know that they no longer have any role for long-term use because chronic steroids can impact almost every organ of the body in a negative way. So they can lead to sleep disturbances, mood disturbances, eye changes like cataracts or glaucoma, risk of diabetes, which then leads to risk of heart disease, osteoporosis, and multiple other things. So we do everything in our power to limit steroid use in patients with inflammatory bowel disease. So what do we use? So in 2023, I'm very excited to say there are multiple small biologic and small molecules that have been designed to have a very targeted approach to immunosuppression. So they're not broadly immunosuppressing and to really heal disease. The first category of these is the anti-tumor necrosis factor agents. The first one was infliximab. It came out in 1998. It's administered over an infusion, and it still has a major role in the treatment of inflammatory bowel disease today. After injectable versions called adalimumab, certolizumab, and golimumab came out, and these can be really wonderful therapies. The next class of drugs that came along in 2014 was vedolizumab, are the anti-integrins. So these work by blocking something in the blood vessel to prevent the migration of white blood cells out of the blood vessel wall to recruit to the site of inflammation. The first one that came out was something called natalizumab that actually bound everywhere in the body. And because of that, the immunosuppressive risks were really high, and we almost never use it anymore. The most commonly one used is called vedolizumab. And vedolizumab is great because it only binds to the alpha-4 beta-7 subunit of this molecule, which is only expressed in the GI tract. So it is not systemically immunosuppressive. It only decreases immune surveillance in the GI tract to prevent inflammation. It is really, really effective for people with Crohn's and ulcerative colitis that have predominantly colon-related disease. A newer class that came out approved just for ulcerative colitis is something called ozanimod. And rather than preventing the migration of white blood cells, it actually sequesters them or holds them in the lymph nodes. Another class is anti-IL-12 23s, so ustekinumab, or isolated IL-23 inhibitors. These work along a systemic inflammatory pathway that's similar to parallel to anti-TNFs and can be a very effective. Ustekinumab is FDA approved for both ulcerative colitis and Crohn's, where risankizumab was just FDA approved in 2022 for Crohn's alone. And then lastly, the JAK-STAT inhibitors. So these are small molecules. They are not monoclonal antibodies, so you can't build up immune tolerance to them. And there's two that are FDA approved right now, tofacitinib for ulcerative colitis, and as of yesterday, upadacitinib for both Crohn's disease and ulcerative colitis. The great thing about these small molecules, again, is you can't really build up a tolerance to them because they're not antibodies and they work really quickly. So how do we choose amongst all of these medications what is right for you? Well, this really is a very personalized approach. So we want to know your type of inflammatory bowel disease. What is your Crohn's phenotype? What is your ulcerative colitis severity? How bad are your clinical symptoms? Because we need to know whether or not we need something that works really quickly, or if we have the luxury of time to get something that may be slightly more effective over the long term, but that we can kind of wait for it to start working. what other medical conditions do you have? So if you have severe heart failure, for example, we can't use anti-TNF medications. And so we need to if you want to get pregnant, for example, there are some medications that are very safe during pregnancy and some that we would not use. And so we do want to know about your whole medical history. Do you have other extraintestinal manifestations? Anti-IL-12-23s or 23s are amazing for psoriasis. So if you have IBD and psoriasis, we would probably choose that first. Do you have, spondyloarthropathy, or where you have inflammatory arthritis of your low back, or peripheral arthritis? We might choose an anti-TNF first. And then past therapy failures and why they failed. This is of critical importance. So if you formed antibodies to adalimumab, but it initially worked great for you, then you might be a candidate for another anti-TNF in the future if we kind of boost it up with another medication to prevent antibody formation. But let's say you had great levels of adalimumab and you still weren't doing well, then that mechanism of drug doesn't work for you. So understanding why they failed is of critical importance. Mode of administration is also important to many people. There are some people that are like, yeah, sure, I can do an infusion where I sit in a chair and it drips into my arm. There are other people that, feel really strongly about doing or not doing home injections or needing an oral medication. And then lastly, and very sadly, insurance coverage does weigh in. We spend a lot of time fighting insurance to get medications for our people. And in fact, at MGH have a whole team that does this for us because we want to get the med that's right for you, not what insurance says. Just like there's not a one-size-fits-all approach when we first choose to start a drug, there's also, not a one-size-fits-all approach as you kind of receive this medication and have response. There are some people that are non-responders, partial loss of response, and people that achieve sustained remission. So again, understanding why and doing that detective work helps us understand what is going to be the next best medication for you. This is some data about kind of loss of response over time. So back when all we had was anti-TNFs, we knew that there was a certain kind of loss of response rate. So the dotted lines here, the black solid and then dotted lines are infliximab alone, and then infliximab with use of an immunomodulator, so like azathioprine or methotrexate. And then the gray lines are adalimumab alone or adalimumab with a immunomodulator. And in general, with infliximab alone, we can see actually about 50% lose response at 1 year. And then for all of these curves, we see about 15% additionally lose response each year. But we do know that with use of medications like immunomodulators, we can really boost rates of remission by decreasing antibody formation. What about the newer drugs that stimulate the immune system a little bit less? There are still rates of loss of response, but actually not as much as we see with anti-TNFs. So this is ustekinumab, and only look at the dotted line here. This is on every 8-week use, which is what's FDA approved for Crohn's disease and ulcerative colitis. The lower line is on an every 12-week dose, which we don't use for IBD. And you can see this study enrolled only people that were responders at the beginning. So for 44 weeks, people did amazing on ustekinumab. What happens over the long term? So from week 44 to week 152. And we can see if everybody started by responding, about 10% of people lost response on the every 8-week regimen during this time. One promising piece of data is we know that by bumping people up to every 4 weeks, we can actually regain about 5% or about 50% of those people, which brings the long-term response rate up to 95% amongst the people that originally responded. So how can we overcome these things to kind of optimize your therapy and keep you on it for a long time and keep you healthy? Well, we know that low drug levels can be associated with poor outcomes and safety issues. So one thing we can do is actually check something called the trough level in antibodies, most commonly used for anti-TNFs. And based on these numbers, either increase your dosing, your frequency, or both. And we can do this proactively to make sure that you're not going to form antibodies against the drug. We can also add an immunomodulator to prevent antibody formation and increase drug levels. This is off-label, but has been shown to improve clinical outcomes. We do sometimes deal with difficulties with insurance coverage of the lab draws for this, but this is something we're fighting hard for because we know that it can be really effective. We can also optimize therapy by monitoring your symptoms really closely. So if you have kind of rebound or worsening symptoms as you get up towards your next infusion, we can actually empirically move up the dosing to make it so you kind of reach a steady state of feeling well. And we know that's been associated with better endoscopic outcomes. So I want to introduce kind of a new concept, and this is combination biologic therapy. So this is using 2 or more treatments of these biologic or small molecules to achieve a synergistic effect. When would we do this? Because it seems pretty immunosuppressive. Well, maybe your IBD is really well controlled, but your extraintestinal manifestations, your skin, your joints are uncontrolled. Well, we might think about 2 or more modalities. Maybe your disease is refractory to one therapy alone, and 2 can actually be really helpful by hitting it from 2 different targeted pathways. And then potentially for induction therapy. So the small molecules are kind of the newest thing. The JAK-STAT inhibitors are kind of the newest thing to come to market. And we know they work really fast. In the clinical therapies for the clinical trials for upadacitinib for ulcerative colitis, they were shown to work within 1 day, but they might have a little bit less of a favorable safety profile than other medications like ustekinumab and vedolizumab. So we could potentially use combination to get you into remission quickly in a steroid-free way, and then peel off the drug with a kind of worse, quote, worse safety profile to keep you on something long-term to maintain remission. There's really limited data for this, but it is growing over time. And obviously using multiple immunosuppressants is something where we have to have a very close eye on safety. This is the most recent trial looking at combination therapy, just demonstrating that it can be effective. This is called the Vega trial and for ulcerative colitis. And what they did is they looked at patients on golimumab, which is an anti-TNF alone, and patients on guselkumab, which is a not yet FDA-approved anti-IL-23 therapy for ulcerative colitis alone. And then both the anti-TNF and IL-23, again, they work along parallel pathways in combination. And as you can see here, the combination of medications was more effective at weeks 12 and 38 than each medication alone. So again, this is kind of a novel and growing idea, and how to optimally combine these medications to improve patient outcomes is something we're working really hard on. So the last thing is treatment or medication forever? So this is something that patients ask me all the time when we're starting a medication. Well, how long am I going to be on it? Am I going to be on it for the rest of my life? And, you know, I think this is a really daunting thing for many people because we do use these medications long-term, but I think saying forever is totally unfair and is very kind of a scary idea. And so I like to tell people there is potentially a chance for de-escalation in the future, but we really need to be careful with how we do it. So this is a study of patients, a small study, only 115 patients that were on infliximab. And again, all of them were in remission, right? Proportion without relapse was 1. So everybody in remission at the start of the study, and they peeled off or stopped the infliximab. And what you can see is at about 1 year off of infliximab, about 50% of people actually relapsed. And over time, it reaches actually close to 60% of people relapse. And so this is the number that I cite for people. Well, that means 40% over, you know, even potentially several years don't relapse. And we know this is a relapsing and remitting disease. So how can we de-escalate people safely? Well, again, it needs to be somebody, the right patient, somebody that is in truly deep remission, confirmed endoscopically, confirmed by imaging, mucosal healing. Things look really great at the time we de-escalate them. The right time, I like to make sure that people have been in remission for at least 2 to 3 years before I consider stopping. And so that's the timeline that I tell people when I start medications. And then we need to have a very clear monitoring strategy. So, okay, when we stop this drug, are we going to check your calprotectins? When are we going to do another colonoscopy to make sure things are okay? And as long as people have, that regular follow-up and a great monitoring strategy in place, this is something that's possible. Knowing though, that ultimately more than 50% of patients do relapse and need to go back on therapy. I think the promising thing is we know that restarting the same therapy actually can be very effective for most people. So, in summary, IBD is a chronic progressive disease that's driven by a dysregulated immune response. We know that early and effective treatment with a biologic or small molecule can control inflammation to prevent bowel injury and damage. We really no longer do step-up therapy at all in Crohn's disease, and only rarely in ulcerative colitis, because we know that if we target the therapy early, we can really change people's outcomes. Biologics and small molecules are safe and they improve quality of life, avoiding steroids. Selection of therapy should be a joint decision based on efficacy, safety, and what you feel like you can actually do in your daily life. And then with the growing treatment options, a really precision-directed management will provide kind of optimal patient outcomes. Thank you.
Thank you so much, Dr. Burke. We are now at the end of the session, so if you have any questions, feel free to enter them in the chat. We have a question regarding therapies for it. In the study reviewing IL-23 and anti-TNF combination therapy compared to the medications individually, did they find worse safety endpoints with the combination group?
Thank you so much, Tate. So yes, they actually did. I don't believe it reached statistical significance, but there were numerically higher, there was a numerically higher number of safety events in this group, which is why, I think larger studies and really careful attention to what biologics we combine will be critically important.
Thank you. And for those who may be new to IBD, can you share a little bit more about it? For instance, some common symptoms and how it's generally diagnosed?
Oh, yeah. So inflammatory bowel disease, again, there's kind of a range of symptoms, and it depends on what kind of disease you end up being diagnosed with. So for ulcerative colitis, again, this only affects the colon, and based on kind of your distribution of disease changes the symptoms that you might have. So if you have disease confined to the rectal area, patients often have severe urgency where when they have to go, they only have seconds to make it to the bathroom, and might have more kind of bleeding or the sensation where they have to go, but actually nothing's there because the inflammation is just grating and making it feel like a bowel movement, something called tenesmus. So those are the most common symptoms if you have just disease confined to the rectum. Or if you have more extensive disease, the most common symptoms of ulcerative colitis are really bloody diarrhea, and the severity of it, the severity of the inflammation changes, I guess, how bad that is. So people with what we call acute severe ulcerative colitis might have a bowel movement every hour, including overnight, where, people with more mild disease may just have, a few a day, but still bloody, uncomfortable, associated with some belly pain. Crohn's disease, it really depends on where the disease is involved, and the symptoms can vary a lot more. And as I showed in one of the plots, some people might not actually have a lot of symptoms at all, but have severe disease. There's a lot less of a kind of one-to-one correlation with symptoms with Crohn's. If you have Crohn's involving your colon, it can behave a lot like ulcerative colitis, where people have, bloody diarrhea, abdominal pain. If it's involving the small bowel, depending on the phenotype, if it's stricturing or you have those tightenings, people might present or have pain and a blockage when they're first diagnosed, or just have some pain and watery diarrhea. And then with upper GI symptoms, Crohn's, which is actually rare, but something we see at our tertiary care center, people may have issues with swallowing or, pain with digestion. And so it really does vary a lot more with Crohn's.
Thank you. How do you go about moving patients from step-up medications to biologics?
So, Rachel, thank you so much for this question. I think it really is an individualized approach. So it really depends on kind of the disease activity. If you mean logistically, if somebody, let's say somebody's been maintained on a thiopurine for a really long time, these are, immunomodulators that we don't really use alone anymore. What we would do is we would think about what kind of biologic you would tolerate the best. And we often overlap them. We just start the biologic while you're still on the immunomodulator. And then we would peel it off once we know that you're tolerating it really well and you're still in remission. Then we would peel off the immunomodulator or stop it 3 to 6 months later. And so there is a period of overlap. If we are stepping up a medication, like let's say you have ulcerative colitis, and we're stepping up because you were on mesalamine, but you're still having bloody diarrhea, you're still having pain, we still do an overlap, but we just start the biologic or small molecule. And then once you're in deep remission, we peel off that 5-ASA, or if you're not the mesalamine, or if you're not tolerating it all, we'll just stop it on the spot. And so logistically, it's not really a challenge. There is, you definitely can overlap if you need to. And it's a very individualized conversation about what medication is best for you next.
Thank you.
So Rachel says, do you initiate the process away from step-up medications even without symptoms in favor of biologics being better long-term? This really is an individualized approach again, and it varies based on the patient and the physician. So let's say somebody has been on a thiopurine, azathioprine for 30 years, and they're doing awesome, and they're in deep remission. Well, many people take the approach that if it's not broke, don't fix it. And we leave you on that medication. But other people may say, I'm in deep remission and feeling great on this medication, but my physician keeps cutting off, my dermatologist keeps cutting off basal cell, skin tumors, which is a long-term side effect of something like azathioprine. Well, then it's worth having a conversation saying, it might be a gamble if we take you off this medication. We may not find a biologic that is effective for you, or we may. But it could, the risks and benefits of that change are really an individualized conversation. There are some really young people who come to our practice that are on thiopurines or methotrexate monotherapy, which actually has a reasonable safety profile, that want to understand other options. And I think as long as we know the risks and benefits of making the switch, for the right person, we do it thinking about the long-term side effects.
Thank you. Can you discuss the combined biologic and immunomodulator therapy?
Yes.
Is this to prevent antibodies? May have misunderstood the application.
Yeah, totally. So I apologize if I didn't explain this well. So for combination biologics and immunomodulators, the real main use for this is actually for people that are on anti-tumor necrosis factor agents. So this is like infliximab, adalimumab, certolizumab, golimumab, those 4 medications. We know that for some reason, these medications are more, quote, immunogenic. They stimulate the immune system to form antibodies a little bit more readily. And these antibodies are what we call neutralizing antibodies. So when the level of antibodies against the drug goes up, the blood level of the drug that can actually treat you goes down. So if you have enough antibodies, the drug stops working. So there are 2 things we do to combat this now. What typically many of us, again, it's not an FDA approved, it's an off-label indication, but most IBD doctors do this now, is when we start you on an anti-TNF, let's say you have non-complicated disease, and we can go into what that means. But let's say you have non-complicated disease, standard ulcerative colitis, for example, or moderate Crohn's disease, for example, that's just inflammatory, no strictures, no fistulae. What we would do is we would start the anti-TNF. And at week 14 for the infliximab, or before the 4th dose of one of the injectable ones, we would actually check levels in antibodies. Let's say the level is like perfect, and each one has a goal level. then that's great. We actually just keep you on that therapy and you're doing great. We keep you on that therapy and we watch you. We don't add an immunomodulator. But let's say the level is actually slightly low, and then you have formed a small number of antibodies against it. Well, we actually can what we call recapture you and like allow this drug to work for a long time for you if we add an immunomodulator. And so oftentimes we either bump up the dose or frequency, add an immunomodulator to prevent antibody formation. And a lot of times those low level antibodies just go away and make the drug totally usable for you long term. So that's kind of the use of them. And people with complex Crohn's disease, so people that already have strictures or fistulae at the time of diagnosis, we actually often start the anti-TNF with the immunomodulator at outset because the evidence shows, like the data shows that that is better for long-term patient outcomes.
Thank you.
I hope that's clear, John. You feel free to message again if I didn't make sense.
For those who are looking to learn more about IBD, management of symptoms, including comparing the different therapies, do you have any online resources that you recommend one visit?
So the Crohn's and Colitis Foundation actually has really excellent patient materials. We also have a lot of patient materials looking at the different therapies for inflammatory bowel disease and the risks and benefits. If you are seen in our center, we can actually provide those handouts for you. And we are rebuilding our website to have those handouts all readily available. And so I think those are kind of the best resources right now to compare.
Thank you. Aside from medications, have you found any foods or lifestyle modifications that could help with the symptoms?
This is actually a really critical question and something that we're certainly very interested in at our center. Our center is kind of a hub of dietary research for inflammatory bowel disease. So we know that there are certain diets that are pro-inflammatory, that cause more inflammation. And we also know that there are certain diets, anti-inflammatory diets, that help so much with clinical symptoms. But where we are in our research, we haven't found like the perfect diet that can put people into deep healing. So we know that we can treat people's clinical symptoms through diet, but that endoscopic remission is something that we haven't achieved yet, and we're still continuing to study. But this is an area of really great interest to us. We actually have an embedded nutritionist in our center who is also helping look at this, and we are doing many clinical trials in this area. I think, diet can be great if you can use it to mitigate symptoms, but I also think that we have to be really thoughtful because many of these diets are very restrictive, and we want to make sure that people are maintaining their weight, maintaining their calories, and not kind of obsessing over every food. And so I think it is a really tricky and individualized balance right now. There are other natural therapies that can be really helpful for symptoms, especially for very mild disease and to help maintain remission for things like mild ulcerative colitis. So things like curcumin or turmeric, I think the studies show 3 grams a day can be effective. There are certain probiotics that are proprietary, so I won't name them, but have clinical trial data that show that they're good for maintaining remission. I think the problem is once you develop like really severe disease, like stricturing or fistulizing Crohn's disease or severe ulcerative colitis, these therapies, again, don't really lead to that endoscopic remission, which we know is the thing that's going to change your outcomes for the better.
Thank you. And in your experience, when patients see you at the clinic, is this something that, they can graduate from, or is this something that it's like a lifelong where they will continually follow up with you?
Yeah. So one of the reasons I became an inflammatory bowel disease doctor is I actually, love the long-term relationships that I have with my patients. When I first meet somebody, I actually see my patients very frequently, like every 3 to 4 months, especially when I start them on a therapy, because I want to monitor, like, is the therapy going well for you? Are you having any side effects? Are we achieving that deep remission? Once people achieve deep remission and their drug levels are good and I know they're doing okay, then I graduate them to less frequent visits. But even if we stop therapy and you're in deep remission for a long time, I want to have at least that every 6-month or annual follow-up to make sure that you're still doing well. Unfortunately, there's no cure for inflammatory bowel disease yet. So making sure we're doing everything proactively to keep you in remission, I think, is critical.
Thank you. We're going to see if there are any additional questions in the chat while we wait. Do you have any final thoughts you'd like to share with the audience, Dr. Burke?
I don't think so. Thank you so much for having me today.
Great. Thank you so much for taking the time to join us. And for everyone who was joining us today, thank you so much. Hopefully you found today's session helpful. As I had mentioned, today's session is being recorded. You may visit the Blum Center website at massgeneral.org/Blum-Center, and it should be posted within a few weeks. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.